You know, over the past 3 decades, there have been some remarkable advances in the treatment of ALL for kids. And some subgroups, however, of children probably receive intensive regimens that are likely to be overtreated and may well be cured using less intensive regimens. So this could result in reduced toxicity and fewer long-term side effects if you come up with a better way of dosing for this. So we're here to talk about new data from the study that you may first have heard about a half dozen years ago or more. And I'm with Professor Martin Schrappe, who is an MD and Professor of Pediatrics and Director of the Department of General Pediatrics at the University Medical Center in the University of Kiel in Germany. Now, you published the results of the AIEOP-BFM ALL 2000 trial in blood back in 2010. So for the first time, you introduced standardized quantitative assessment of minimal residual disease. Talk about that for the first part of this.
Thanks. This was a very big step for us forward in risk classifying our patients, because response seems to be the most individual, the strongest prognostic factor in childhood leukemia, but probably also in other leukemias.
So back then in 2010, what were you reporting?
2010, we were reporting the overall results of that study, but not going into the details of the standard risk patient that I'm talking about here at this meeting. We were, stepping into a big bowl of water because we didn't know if it's feasible to do MRD in so many different centers, so many different labs with the same standards of quality.
So here you're presenting reduced intensity, delayed intensification in standard risk patients defined by minimal residual disease in childhood acute lymphoblastic leukemia. Tell us about this particular study you're presenting here.
We were really amazed that MRD can predict outcomes so precisely. So there's a large group of patients in whom we find a very low risk of relapse, if any. And this was never achieved before. So we were really happy that we could assign about 40% of the patients to a low-risk group, so-called low-risk group, in which we thought it's necessary to get away from the more toxic parts of treatment, not at the beginning, but at later stages of treatment.
Now, you have about a median follow-up of almost 9 years.
Well, this is necessary because in low-risk leukemia, relapses occur late. They are not the early relapses. This happens in the high-risk leukemia subset.
So what have you found?
Well, we found that it is sort of dangerous to reduce treatment without control. That's why we did this in a controlled fashion, in a randomized fashion. And after now many years of observation, you just mentioned it, we see that reducing treatment is probably dangerous. It's not causing big trouble, but it's causing significant trouble. So one should be very careful. Negativity in minimal residual disease does not mean you are cured.
Interestingly, you had nearly identical disease-free survival and cumulative incidence of relapse as DCOG 11, which was a previous examination, correct?
Well, this is a study which was, in the first part, very similar to ours. However, they found a few less standard risk patients, so they had a smaller group, and they didn't do it randomized. So the results are similar, but they're not identical.
Well, and the fact that you really need to randomize is kind of the bottom line of this study, doesn't it?
It is. That's absolutely true. I think if we would not have randomized this, we would not have found the difference.
So what's the take-home message? Be very careful?
If you have reached such a plateau of cure, above 90%, be careful, because you cannot play around with the disease. I think this is dangerous.
That's a very good take-home message. So are you going to do anything else? I mean, are you simply just not going to use this yourself in many ways?
Well, we have tried this before to reduce treatment, and some years ago we completely omitted delayed intensification, and this was quite a disaster, to be honest. But it's published. So this time we were more careful. We thought minimal residual disease would allow us to do so, but it's not possible. It's sort of dangerous. However, I can imagine in the long run we will be able to identify subsets of patients through genetic screening which can be treated successfully, maybe cured in all cases with different type of therapy.
And it's what I said at the top. you don't want to overtreat.
You don't want to. That's right.
But you also don't want to undertreat.
Yeah, and also we should remember that the vast majority of leukemia kids is surviving without late sequelae.
Right.
Well, this is a good message.
Oh, I think it's a great message. So please, we have a lot of coverage from the ASH 2016 meeting. Please look around for that here online as well as in ASH Clinical News. I'm Rick McGuire.